Good afternoon. The topic of today's practical is investigation in anemia, which includes a complete blood count, RBC count, and the hemoglobin estimation. Competency of the today's practical is enumerate and describe the investigations of anemia. The learning objective of practical is investigation required CBC, which includes hemoglobin, total RBC count, which includes hematocrit, RBC indices, and RDW. Demonstration of the Salis method of the hemoglobin estimation. Add on the investigations of reticulocyte count, sickling test, and HPLC. Machinery required for the above test. Briefing about the automated cell counter and how to run them. And flow chart about when to order what. So we'll see one by one. First, we will start with a hemoglobin estimation. So, what is hemoglobin? Hemoglobin is a conjugated protein present in the red blood cell. When fully saturated with oxygen, that is a 4 molecule of it, is called oxyhemoglobin. Hemoglobin returning with a carbon dioxide from the tissue is known as a reduced hemoglobin. Now, what are the types of the hemoglobin? There are various normal hemoglobin and abnormal hemoglobin. Normal hemoglobin includes adult hemoglobin, fetal hemoglobin, and embryonic hemoglobin. The adult hemoglobin includes HbA and HbA2. HbA has a 2 alpha and 2 beta chain, which constitutes a 97% of the total adult hemoglobin. And hemoglobin A2 is a minor hemoglobin present in the adult containing the 2 alpha chain and 2 delta chain. Now fetal hemoglobin, HbF. It is a major hemoglobin in the intrauterine life and containing a 2 alpha chain and 2 gamma chain. Then hemoglobin BAT. It is a minor hemoglobin present in the fetal life. It consists of the 4 gamma chains. Its concentration increased in the thalassemia. Now embryonic variant of the hemoglobin. It confined to the very early stage of the development. HB Gower 1, HB Gower 2, and the hemoglobin Portland. The first Gower 1 hemoglobin have a 2 zeta chain and 2 epsilon chain, and the hemoglobin Gower 2 has a 2 alpha chain, 2 epsilon chain, and the hemoglobin Portland has a 2 zeta chain and 2 gamma chain. Abnormal hemoglobin these are the 4 clinically important abnormal hemoglobin. Hemoglobin S, sickle cell hemoglobin, hemoglobin C, hemoglobin D, and hemoglobin E, which is present in the various different hemoglobinopathies. Now unstable hemoglobin. Hemoglobin variant that undergo denaturation and precipitate in the red cell and seen as a hen's body. Now what are the hemoglobin complex? It's called when the hemoglobin combines with the other substance. First is a carbaminohemoglobin. In this, the carbon dioxide combines with a hemoglobin. It combines with the globin part of the hemoglobin and not with the heme. Next is a carboxyhemoglobin. When the hemoglobin combined with the carbon monoxide, it is called carboxyhemoglobin. Hemoglobin has a much greater affinity for the carbon monoxide than the oxygen. The formation with a carbon monoxide is reversible. So, if the carbon monoxide is removed from the blood, the hemoglobin again combined with the oxygen. Next is methemoglobin, in which the iron is oxidized from the ferrous state to the ferric state. It is capable of carrying oxygen. Incapable of carrying the oxygen. The formation is reversible. Next is a sulf-methemoglobin. It is formed by the action of some drugs or chemicals. Once it is formed, it is irreversible and remain in the carrier RBCs. It is incapable of transporting the oxygen. Cyan-methemoglobin is formed by action of the cyanide. To measure the total hemoglobin amount accurately in the blood, it is essential to prepare stable derivatives that will contain all the hemoglobin forms which is present in the blood. All forms of the circulating hemoglobins are readily converted to cyan methemoglobin except for the sulf methemoglobin, which is normally not present in a blood. Therefore, the cyan methemoglobin method is a most accurate method for the determination of the hemoglobin. Now, what are the indications for the hemoglobin estimation? First is to determine presence and the severity of the anemia. Clinical diagnosis of the anemia, such as a pallor of the skin and conjunctiva, mucous membrane, and are the less accurate diagnosis of the anemia. The screening test for the polycythemia to assess the response to the specific therapy in the anemia, estimation of the red cell indices, and the selection of the blood donors. Now, what are the different methods for the estimation of the hemoglobin? First, colorimetric method, second gasometric method, third chemical method, and the fourth is specific gravity method. Colorimetric method, in which the color comparison is made between the standard and the test sample, either visually or either by the colorimetric method. First visual method and second is photometric method. We'll see one by one. First, in the visual method is a Tolquist method. A Tolquist hemoglobin chart consists of the serial of the lithographed color corresponding to the hemoglobin value, ranging from the 10 to 100%. A drop of the blood obtained by the finger puncture is placed on the piece of the absorbent paper. Color produced is matched against the color on the chart and the corresponding reading is taken. It is a cheap method, but the margin of the error is 20 to 50%, so it is obsolete now. Second method is a Sally's acid hematine method. First principle. Hemoglobin is converted to acid hematine by the action of the HCl. The acid hematine is further diluted until the color matches exactly with that of the permanent standard of the comparator box. The hemoglobin concentration can be read directly from the calibrated tube. Now, what are the equipment needed for that? First is a Sally's hemoglobinometer containing the comparator, hemoglobin tube, hemoglobin pipette and the stirrer. Second is a N/10 HCl, distilled water and dropper. First comparator. At the middle there is a slot in which accommodate the hemoglobin tube, and the standard brown tinted glass pipette are provided on the either side of the slot for the color matching. Now, hemoglobin tube. It is graduated on a side in a gram percentage from 2 to 24, and the other side is a percentage from 20 to 140. The tube is called Charles-Adams tube. The hemoglobin pipette. The pipette bears only one mark indicating a 20 cubic mm. There is no bulb in this pipette. Stirrer. It is a thin glass rod used for stirring the solution. Now, specimen. Immediate anticoagulated venous blood or blood obtained from the skin puncture is used. Now, procedure. Fill the hemoglobinometer tube with a N/10 HCl up to its lowest mark, 2 gram, with the help of the dropper. Fill the hemoglobin pipette with a blood up to 20 cubic mm. The blood adhering to the exterior of the pipette is wiped away using the absorbent paper or gauze. Immediately transfer the blood into the hemoglobinometer tube. Mix with the glass stirrer and allow it to stand for the hemoglobin. This is the time for the maximum conversion of the hemoglobin to the acid hematine. Then place the tube into the slot provided in the comparator. And now add a distilled water drop by drop till the color of the solution match with a brown glass standard. Take the reading of the lower meniscus from the graduated tube in grams. Now, reporting. Hemoglobin estimation can be reported either as a percentage of the normal or as a gram per 100 ml. Usually is reported as a gram per 100 ml. Although the graduated tube is marked in the both gram and percentage figures, the result should always be reported in the gram per 100 ml because no single value can be considered as 100% since it varies with the age and sex of the individual altitude. Hemoglobinometer of the different manufacturer have a different value of the 100%. So the sample of the blood will yield the different result of the different instrument. Now advantage of this method is easy to perform and very convenient, and the cost is minimal. There are various disadvantages. First is being the visual method, error is very likely. The error can be reduced by taking the average of the three readings. The first, when the color is darker than the standard. Second, when the color is exactly match the standard. And third, when the color is slightly lighter than the standard. The color of the standard may not always be reliable, especially in the old apparatus because the old apparatus become fade. This method does not estimate all the hemoglobin. It estimates only oxyhemoglobin and reduced hemoglobin, not carboxyhemoglobin, methemoglobin or sulfamethemoglobin. Fourth is fetal hemoglobin is also not converted to acid hematine, so it is a not suitable method for the infant. Source of the light will influence the visual apparatus. Color. The development of the color is slow and the acid hematine solution is not stable. About 95% of the color of the acid hematine is attained at the end of the 10 minutes. So for the maximum color development, much longer time is required. Next method is a WHO hemoglobin color scale. This method is similar to the Tolquist method. The certain technique modification have been made to improve the accuracy and reliability. The hemoglobin color scale consists of the printed set of the color corresponding to the hemoglobin value ranging from the 4 to 14 grams per dl. A drop of the blood is placed on the strip of the chromatography paper and the color developed is matched visually against a printed color scale. It is useful at the field level for the screening purpose. This is the hemoglobin color scale. The color is matched with various readings. Next method is a sign meth hemoglobin method. This is the method of choice for estimation of the hemoglobin. It is recommended by the International Committee for the Standardization in the Hematology. This is because all the forms of the hemoglobin are converted to the sign meth hemoglobin except sulfameth hemoglobin, which is absent in a normal human being. This is a stable and the reliable standard is available for it. Principle. In this, the blood is mixed with the Drapkin solution, potassium ferricyanide, potassium cyanide, non-ionic detergent. The erythrocytes are lysed, producing an evenly distributed hemoglobin solution. The potassium ferricyanide converts the hemoglobin to the methemoglobin, and the hemoglobin combines with the potassium cyanide to form a sign meth hemoglobin. All the form of the hemoglobin present in the blood are completely converted. When the reaction is completed, absorbance of the solution is measured in the spectrophotometer at a 540 nanometer. To obtain the amount of the hemoglobin in the unknown sample, absorbance is compared with the standard by using a formula or a previously prepared graph or table. Procedure. In this, the test tube, take a 5 ml of the Drapkin solution to it. Add a 0.02 ml of the blood. Mix well and allow it to stand for 5 minutes. This time is adequate for the conversion of the hemoglobin to the sign meth hemoglobin. Transfer the sample to the cuvette and read the absorbance in the spectrophotometer at the 540 nanometer wavelength. And also take absorbance of the standard solution. Notes. Lipemic blood, high leukocyte count more than 25,000 and abnormal plasma protein can cause the erroneous result. The solution is stable so that delay in taking the reading of the absorbent does not affect the result. Next method is a oxyhemoglobin method. The blood sample is mixed with a weak ammonia solution. Absorbent of this solution is measured in the spectrophotometer at the 540 nanometer wavelength and compared with the standard. Advantage is it is a rapid and simple method. And disadvantage is no stable standard solution is available for this. Color of the oxyhemoglobin solution is fades rapidly. The hemoglobin derivatives other than the oxyhemoglobins are not measured. Now, next method is the specific gravity method. It is commonly used for the selection of the blood donors in the blood banks. A drop of the blood is allowed to fall in the copper sulfate solution of the specific gravity of the 1053 from a height of the 1 centimeter. The specific gravity of the 1.053 is equivalent to the hemoglobin concentration of the 12.5 gram per dl. The drop of the blood gets converted with a copper proteinates and they remain discrete for the 15 to 20 seconds. If the drop sinks within this time, the hemoglobin is more than 12.5 gram per dl. If it floats on the surface, hemoglobin level is unacceptable for the blood donation. Next method is a gasometric method. It measures the hemoglobin by using a Van Slyke apparatus. More complex method. This method measures only physiologically active hemoglobin. It does not measure the carboxyhemoglobin, sulfahemoglobin and the methemoglobin. This is all about the method for the estimation of the hemoglobin. You will asked to perform a Charlie's acid hematine method in your practical examination. So you have to learn by heart this method, and the Viva question will be asked about all this method and principle of this. So it is very useful for you. Now reference range is in adult male 13 to 17 gram per dl, in adult female non-pregnant 12 to 15 gram per dl, in adult pregnant female 11 to 14 gram per dl, in the children 6 to 12 years 11.5 to 15.5 gram per dl, in the children 6 months to 6 years 11 to 14 gram per dl, in children 2 to 6 months 9.5 to 14.5 gram per dl, at a birth full term 13.6 to 19.6 gram per dl is a normal range of the hemoglobin. Now next is a PEG cell volume hematocrit. The volume occupied by the red cell when the sample of anticoagulated blood is centrifuged. Indicates a relative proportion of the red cell to the plasma. The uses of the PCV: detection of the anemia or polycythemia, estimation of the red cell indices, checking the accuracy of the hemoglobin value. Hemoglobin in the grams per dl into 3 equal to PCV. The method for the estimation of the PCV: first, macro method by the Winthrop's tube and micro method by the microhematocrit tubes. First, we will see by the Winthrop's tube. Principle of this test is anticoagulated whole blood is centrifuged in a Winthrop's tubes to completely pack the red cell. The volume of the packed red cell is read directly from the tube. Specimen: the venous blood collected in a EDTA or a double oxalate. The test should be performed within the 6 hours of the collection. What are the equipment required for this? First is Winthrop tube. It is a 110 mm long with a 3 mm internal diameter, graduated from 0 to 10 cm with a graduation both ascending and descending order on the both sides of the tube. Marking 0 to 10 cm from the above downwards or descending order is for the ESR, while the scale of 0 to 10 from the below upwards is used for the measurement of the PCV. Second is a Pasteur pipette. It is a rubber bulb and a sufficient length of the capillary to reach the bottom of the Winthrop's tube. Centrifuge with a speed of the 2300 rpm. Method: mix the anticoagulated sample thoroughly. Draw the blood sample in the Pasteur pipette and introduce the pipette up to the bottom of the Winthrop's tube. Fill the tube the bottom exactly up to the 100 mark. During filling, tip of the pipette is raised but should be remain under the rising meniscus to avoid a foaming. Centrifuge the sample at a 2300 rpm for a 30 minutes. To counterbalance, the second Winthrop tube is placed in the centrifuge at the opposite side. Take the reading of the length of the column of the red cell. While taking the reading, exclude the buffy coat. Significance: the PCV low is in iron deficiency anemia and raised in the dehydration, shock, burns, polycythemia. This all condition. Advantage of this method is a ESR can be determined simultaneously by using the same sample. For this, first Winthrop's tube is filled with the blood kept vertically in the Winthrop's rack for 1 hour. ESR reading is taken, following which the tube is centrifuged to determine the PCV. It is not an expensive method. So in this figure, first is showing the above there is in yellow color is plasma, middle is a buffy coat, and the lower column of the red color is a red cell. So in this, reading is taken from the 0 to 10 below downwards. First is a normal, second in anemia, decreased PCV, and third is a in this the thick buffy coat is present. Micro method. Principle: anticoagulated whole blood is centrifuged in the capillary tube of the uniform bore to pack the red cell. The centrifugation is done in the special microhematocrit centrifuge till the packing of the red cell is complete as possible. The reading is taken using a microhematocrit reader, a ruler, or a arithmetic graph paper. Equipment for this is a microhematocrit centrifuge with a centrifuge force 1200 rpm for 5 minutes. Capillary hematocrit tubes, disposable glass tubes of the 75 mm in a length and a 1 mm in internal diameter. There are of two types, plain and heparinized. Plain containing a no anticoagulant, in which the anticoagulated venous blood is used, while the heparinized coated with a dried film of the 2 units of heparin, in which the blood obtained from the skin puncture is used. Tube sealant like a plastic sealant or modeling clay. Microhematocrit reader. If not available, a ruler or arithmetic graph paper can be used. Method: fill the capillary with blood about 2/3 to 3/4 length of the capillary. Seal the other end of the capillary tube with a plastic sealant. The filled tube is placed in a radial groove of the centrifuge. The centrifuge it for the 1200 rpm for 5 minutes. Immediately remove the tube from the centrifuge and stand them upright. With the reader, hematocrit is directly read from the skin. If the reader is not available, the tube is held against the ruler and the hematocrit obtained by the following formula. In this, a length of the red cell column in mm is divided by the length of the total column in the mm into 100. General remarks. Prolonged the application of the tourniquet causes the hemoconcentration and rises of the PCV. Excess squeezing of the finger during the spine puncture, blood dilutes with the tissue fluid, so it lowers the PCV. Correct proportion of the blood and anticoagulant should be used. Excess of the EDTA causes the shrinkage of the RBC and lower the PCV. If there is a clot in the sample, lowers the hematocrit can result. Centrifugation at the lower speed for the less time, falsely high PCV results. Now rule of the 3 and 9. Commonly used to check the accuracy of the result and the applicable only if the red cells are normal in size and shape. Hemoglobin into 3 equal to PCV and the RBC count into 9 equal to PCV. Automated hematocrit. In automated hematology analyzer, hematocrit is obtained by multiplying the red cell count by the MCV. Reference range of the PCV. In the adult male, 40 to 50%. In adult female, 38 to 45%. In adult female pregnant, 36 to 42%. In a children 6 to 12 year, 37 to 46%. In the children 6 months to 6 year, 36 to 42%. In the infant 2 to 6 months, 32 to 42%. In the newborn 44 to 60%. Critical value of the PCV is less than 20% or more than 60%. Now next topic is RBC count and various RBC indices. For the RBC count, there is a two method, non-automated method, which is a manual method, and second is a automated method. First, manual method. The reagent used is a RBC diluting fluid. It is an isotonic solution. Therefore, it prevents a hemolysis. Himes fluid is most commonly used. The composition of this fluid is a sodium chloride 0.5 gram. It maintains the osmolarity. Second is a sodium sulfate 2.5 gram. It prevents the aggregation of the RBCs. Next is a mercury chloride 0.25 grams, which is the preservative, and the distilled water 100 ml. Equipment is a hemocytometer. The recommended hemocytometer is a one with improved Newbauer's ruling and a metallized surface. There are two ruled areas on the surface of the chamber. Each ruled area is 3 by 3 mm of the size and consists of the 9 large square, with each large square measuring 1 by 1. So you can see in this. Total 9 square is present, which is divided into 16 square. And the central square is divided into 25 squares, which is further divided into 16 small squares. A group of the 16 small square is separated closely by the ruled triple line. And second is a RBC pipette. So the RBC should be counted in a red labeled area. The specimen used for it is the EDTA blood or after the skin puncture. The method: take a blood up to the 0.5 ml mark of the RBC pipette. The blood column should not be contain any air bubble or fragmented. The wipe at the tip of the pipette before diluting the blood. Suck the RBC diluting fluid exactly up to the 101 mark. If the fluid drawn above the mark, then discard and restart procedure. Gently mix the content of the bulb before the charging the chamber. Discard the first 2 drops of the fluid as stem does not make a part in a mixing. Now dilution factor. The volume of the blood is 100 because 101 minus 1 equal to 100. Mixing of the blood and diluting the fluid only occurs in the bulb. Thus, the 100 volume of the diluted blood contains the 0.5 ml of the blood and 99.5 ml volume of the diluting fluid, resulting in the dilution of the 0.5 into 100. Thus, the dilution is obtained is a 1 in a because 101 minus 1 equal to 100. Mixing of the blood and diluting the fluid only occurs in the blood. Thus, the 100 volume of the diluted blood contains the 0.5 ml of the blood and 99.5 ml volume of the diluting fluid, resulting in the dilution of the 0.5 into 100. Thus, the dilution is obtained is a 1 in a 200. Now, calculation. Count the number of the cells in a square in a center of the hemocytometer. This 5 square equals to the 1/5 of the whole central square. So, formula is a number of the cell counted into dilution factor. Volume is 0.1 ml into 1 by 5, or a number of the cell counted into the dilution factor divided into 50 equal to cells per microliter. Normal range for the RBC count is in a male 4.3 to 6.2 into 10 raised to 6 per microliter, and in the female 3.8 to 5.5 into 10 raised to 6 per microliter. So this all about the total RBC count. While in the automated hematology analyzer, we directly get a total RBC count. Now these are the various red cell indices. Main red cell indices are the MCV, mean cell volume. Second is mean cell hemoglobin, MCH. Third is a mean cell hemoglobin concentration, MCHC, and also called an absolute value because these are directly derived from the RBCs. They are the derivatives of the hemoglobin, PCV, and the red cell count. Recently, a newer parameter called RDW has been introduced. First, MCV, mean average size of the red cell. MCV equal to PCV divided by the red cell count in a million per cubic mm into 10. MCV is expressed as a femtoliter or FL. It corresponds with the red blood cell diameter on the blood. Normal MCV is a 80 to 100 femtoliter. Increased MCV seen in a megaloblastic anemia, chronic alcoholism, liver disease, hypothyroidism, normal pregnancy, and the newborn. Low MCV is found in the anemia like iron deficiency anemia and thalassemia. Second is the MCH. It is the average amount of the hemoglobin in a single red cell. It is obtained by dividing the hemoglobin value by the red cell count. MCH equal to the hemoglobin in the gram per dl divided by the red cell count in the million per cubic mm into 10. It expressed as a picogram, and the range is from the 27 to 32 picogram. MCHC, it is obtained by dividing the hemoglobin value by the PCV and expressed as a gram per dl. It refers to the concentration of the hemoglobin in a 1 deciliter of the PCV. Hemoglobin in a grams per dl divided by the PCV in a percentage into 100 is MCHC is raised in the hereditary spherocytosis. Normal value is a 32 to 35 gram per dl. Next is a RDW. It measures the degree of the variation in a red cell size and astrocytosis in the blood. It is a low or normal in a thalassemia trait and high in the iron deficiency anemia. Normal range is a 9 to 14.5. Now, what are the uses for these indices? First, morphological classification of the anemia like normocytic normochromic, microcytic hypochromic, or macrocytic normochromic. Next, differentiation of the iron deficiency anemia from the thalassemia trait. In the IDA, MCV, MCH, MCHC are low, while in thalassemia trait, the MCV and MCH are low, but MCHC is normal. Now, next topic is anemia and its investigation. So, what is the anemia? Anemia is defined as a reduction in the hemoglobin concentration below the level which is expected for the healthy person of the same age and sex. The anemia is usually associated with a decreased level of the hemoglobin and or decreased PCV and or decreased RBC count. So either decrease in the hemoglobin or PCV or decreased RBC count. Occasionally there is abnormal hemoglobin with an increased O2 affinity resulting in anemia with a normal or raised hemoglobin, hematocrit or RBC count. Now the classification of anemia. There are two ways to classification of the anemia. First is etiological and second is a morphological. First we will see the etiological classification. Anemia due to the decreased production of the red cell. It can be due to nutritional deficiency like IDA megaloblastic anemia due to the deficiency of the folate and B12. Second is anemia of the chronic disease, sideroblastic anemia, aplastic anemia, anemia due to the infiltration of the bone marrow by the malignant cell, or anemia of the chronic renal failure. In all these conditions, the RBC production is decreased from the bone marrow. Second is a anemia due to the increased destruction of the red cell. It's called hemolytic anemia, which can be due to the hereditary cause or acquired cause. In the hereditary cause includes a defect in the red cell membrane like a hereditary spherocytosis, hereditary elliptocytosis, defect in the hemoglobin like a sickle cell disease, thalassemia. Next is hemoglobin E disease. Defect in the red cell enzyme like a J6PD deficiency. Next, acquired causes include autoimmune hemolytic anemia, paroxysmal nocturnal hemoglobinuria, hemolytic transfusion reaction, hemolytic disease of the newborn, mechanical hemolytic anemia, hypersplenism, malaria. These all are the acquired causes of the hemolytic anemia. And last is anemia due to the acute blood loss like a hemorrhage due to trauma, massive bleeding or during a delivery. Next is a morphological classification. It is divided into three types. Microcytic hypochromic, in which the MCV is less than 80 femtoliter and MCHC is less than 30 gram per DL. It is seen in IDA, thalassemia, anemia of the chronic disease, sideroblastic anemia. Next is a macrocytic anemia, in which the MCV is more than 100 femtoliter and MCHC is 30 to 35 gram per DL, which is anemia, megaloblastic anemia, alcoholism, liver disease, hypothyroidism, myelodysplastic syndrome, etc. And next is a normocytic normochromic anemia, in which the MCV and MCHC are within the normal range. General symptoms of the anemia are the weakness, malaise, easy fatigability are the common complaints. The lower oxygen content of the circulating blood lead to the dyspnea of the mild exertion. Hypoxia can cause the fatty changes in the liver, myocardium, kidney and may lead to the cardiac failure. First clinical sign looked for the anemia: skin or mucosal pallor, skin dryness, palmar creases, bald tongue, glossitis, mouth ulcer, rectal examination, jaundice, purpura, lymphadenopathy, hepatosplenomegaly, breathlessness, tachycardia, congestive heart failure, bleeding or occult blood. These are the all clinical signs looked for the various classification of the anemia. So what are the various steps we follow in the investigation of anemia? First, history and the clinical examination should be done. Thorough examination for any bleeding is done. Second, hemoglobin percentage, then the RBC and hematocrit measurement, then the MCV, MCH and MCHC. Next is a peripheral smear examination. Then see the red cell distribution width. Fifth is a estimation of the reticulocyte count. Then from all this we can get a brief idea about the type. So we can order the different investigation according to the type of the anemia. If we are supposed to have a picture of the iron deficiency anemia, So the investigation like a serum ferritin, total iron binding capacity, bone marrow iron is done, and classify them into the iron deficiency anemia or other macrocytic anemia. Next, if we have a picture of the megaloblast, so macrocytic megaloblastic anemia, B12 and folic acid, and macrocytic normoblastic anemia. Other investigation is done. Next is a normocytic normachromic anemia, seeing the chronic disease in the hemolytic anemia. For this, the various specific test is done for the various different type. So, in the brief, suspected anemia, estimation of the hemoglobin PCV, anemia present, evaluation of the clinical feature, blood smear, reticulocyte count, red cell indices, morphological classification of the anemia, perform the specific laboratory test, established the cause of the anemia. So, we will see how to approach the anemia. First, we have to establish the presence and severity of the anemia, and second is determine the cause of the anemia. So, how we can establish the presence and severity of the anemia? Laboratory methods are available, like a hemoglobin and PCV. First, hemoglobin. Sign-Black hemoglobin method is of choice. Depending upon the hemoglobin concentration, the anemia is graded as a mild, moderate, and severe. Mild, in which the hemoglobin lower limit of the normal but above the 10 gram per dl. In the moderate, hemoglobin is 7 to 19 gram per dl. In the severe anemia, the hemoglobin is less than 7 gram per dl. Estimation of the second is estimation of the PCV. PCV is about 3 times the value of the hemoglobin concentration, and thus can be used to cross check the hemoglobin value. Hemoglobin percentage less than 12 and the hematocrit less than 38. So, 2 causes are there. It can be either decreased production of the RBC or increased destruction of the RBC. In a decreased production, there is a hyperproliferative state of the bone marrow, and due to hemolysis, there is a increased destruction of the RBC. In this, the hyperproliferative state, the reticulocyte proliferating less than 2, while in the hemolytic anemia, RPI is more than 2. Third is the MCV. RBC size is measured indirectly by the MCV. MCV is can be microcytic, normochromic, or macrocytic. Macrocytic called when MCV is less than 80 femtoliter, normal when the 80 to 100 femtoliter, and macrocytic when the more than 100 femtoliter. Next is reticulocyte count. That's we have seen reticulocyte count decreased production or increased destruction. Now peripheral smear for the cell morphology. See, in the peripheral smear, all the RBCs are of same size. All the RBCs are a normal discoid shape. How is the color, hemoglobin content? All the RBCs are the same color or multicolor. Are the RBC have any inclusions? Have any hemoparasite in the RBC? Any leukocyte normal in the number and the differential count? Is the platelet distribution is adequate? So all these things should be seen in the peripheral smear. Now, after the examination of the peripheral smear, we can conclude what is the type of the anemia, and according to that we have to order the specific test. So, microcytic hypochromic anemia. So first we have to see the serum ferritin. If it is a low, it is a iron deficiency anemia. If it is a normal or increased, we have to look for the thalassemia, anemia of the chronic disease, and sideroblastic anemia. So we have to perform the electrophoresis. If it is abnormal, it is a case of thalassemia, and if it is normal, it can be due to the sideroblastic anemia or anemia of the chronic disease. So we have to do the bone marrow iron stain. If the storage of the iron is increased in the bone marrow, it is anemia of the chronic disease. And if we see the ring sideroblastic in the bone marrow aspiration, it is a case of the sideroblastic anemia. So, in this normally the RBC have a 1/3 of the pillar, central pillar. But in this film, we can see the RBC having a only ring shaped. All the central portion is a pale. So, it is a case of the severe hypochromia. This picture is of microcytic hypochromic anemia. Normally, the size of the RBC is compared with the nucleus of the small lymphocyte. So, the RBC size and the size of the nucleus of the small lymphocyte is the same. In this, we can see the RBC size is smaller as well as the central pillar is increased. In this, you can see the teardrop cells and the pencil cell. Now, iron deficiency anemia summary. MCV is a lower, less than 80. RBC count less than 6 per microliter. IDW widened and shifted to the left. Hypochromia MCH is less than 27 picogram, less than 27 picogram, MCH is less than 30%. RPI is less than 2. Reticulocyte count may be more than 2. Serum ferritin very low, less than 33. TIBC is increased more than 340 microgram per DL. Bone marrow iron stain, iron is absent, and the response to the iron treatment is excellent. So this is all about the iron deficiency anemia. Now, if in the peripheral smear we are seeing the picture of the macrocytic anemia, so we have to go for the reticulocyte count. If it is increased, look for the polychromasia and any evidence of the hemolysis. So it is a case of the hemolytic anemia. And if reticulocyte count is a normal or low, we have to see for the oval macrocytes, hypersegmented neutrophil. It is a case of the megaloblastic anemia. If we are seeing the round macrocytes and the dyshematopoiesis, it is a case of the myelodysplastic syndrome. And we are seeing the oval macrocytes, so we have to look for the liver disease, alcoholism and hypothyroidism. Macrocytic anemia, in which the megaloblastic and megaloblastic anemia is due to the B12 and folate deficiency, and non-megaloblastic macrocytic anemia due to the liver disease, hemoglobinopathies, metabolic disorder, hypothyroidism, myelodystrophy, bone marrow infiltration, accelerated erythropoiesis, increased destruction, drugs like cytotoxic drug, immunosuppressed drugs, azathioprine, anticonvulsant, etc. Anemia is called macrocytic when the MCV is more than 100. The premature grey hair considered the megaloblastic anemia. Macrocytic anemia may be asymptomatic until the hemoglobin level is as low as 6 gram. MCV 100 to 110 must look for the other cause of the macrocytic. If MCV more than 110 femtoliter, almost always there is a folate and B12 deficiency. Macrocytosis of the alcoholism, in which the 25 to 96% of the alcoholism is seen. MCV is elevated, usually slight, 100 to 110. Minimal or no anemia. Macrocytes are round, not oval. Neutrophil and hypersegmented neutrophil are absent. Folate store is normal. Smoking increases the red cell mass. Now, what is a megaloblastic hematopoiesis? In this, the marrow failure is due to the disrupted DNA synthesis and ineffective erythropoiesis. Giant precursor is seen like a megaloblast. In the nuclear feature, cytoplasmic synchrony in marrow. Neutrophil is hypersegmented and macroovelocyte is seen. Anemia is often leukopenia and thrombocytopenia, almost always due to the B12 and folate deficiency. In this, we can see the macroovelocytes and macrocytes. in the megaloblastic anemia, and the neutrophil is a hypersegmented neutrophil within 5 lobes. Anisocytosis, macrocytic anemia. We can see the small RBCs as well as large macroovelocyte, and nucleated RBC is also seen in the peripheral smear. This is a megalocyte in a peripheral smear. You can see the basophilic stippling. This is the same basophilic stippling in a NRBC. Basophilic stippling can also be seen in the lead poisoning. This is the megaloblast in the folic acid deficiency. This can be seen in a bone marrow aspiration. Now next is a normocytic normochromic anemia. So here we have to see for the reticulocyte count. If it is increased, look for the hemolytic anemia and acute blood loss. And if it is low, whether an infection, inflammation, malignancy, chronic renal disease is present or not. If it is present, so cause can be anemia of the chronic disease or chronic renal failure. And if any histories are not present, go for the bone marrow examination and look for the aplastic anemia, anemia due to the marrow infiltration. Normocytic anemia can be due to the chronic disease, chronic kidney disease, early iron deficiency anemia, various hemoglobinopathies, primary marrow disorder, combined deficiency, increased destruction, anemia of the investigation. Anemia of the chronic disease can be due to the thyroid disease, malignancy, collagen vascular disease, inflammatory bowel disease, chronic infection, chronic kidney disease, or renal failure. Approach to the diagnosis of the hemolytic anemia consists of determining the presence of the hemolysis, whether the hemolysis is extravascular or intravascular, then the cause of the hemolysis. So, for the presence of the hemolysis, laboratory features are excessive of the red cell destruction are increased indirect serum bilirubin, increased urobilinogen in the urine, decrease or absent plasma heptoglobin, appearance of the free hemoglobin in a plasma or urine, increased serum lactate dehydrogenase. The 3 typical features indicative of the hemolytic anemia are the low hemoglobin, increased reticulocyte count, and raised indirect serum bilirubin. Laboratory feature in the intravascular hemolysis are hemoglobinemia, decrease or absent plasma heptoglobin, hemosideruria, methemoglobinemia. And for the extravascular hemolysis, unconjugated bilirubin in the serum and urobilinogen in the urine are increased, but hemoglobinemia, hemoglobinuria, hemosideruria, and methemoglobinemia is absent. Now third is defining the cause of the hemolysis. Usually clinical feature and the morphology of the red blood cell smear suggests the probable cause of the hemolytic anemia. Specific laboratory tests are then carried for the definitive diagnosis. These specific tests are for the hereditary hemolytic anemia, hemoglobin disorder. For this we have to go for the sickling test, hemoglobin electrophoresis, HPLC, estimation of the hemoglobin A2, estimation of the hemoglobin F, red cell inclusion. Now for the red cell enzyme defect, we have to do test for the G6PD deficiency. For the red cell membrane defect, we have to do osmotic fragility test. For the hereditary spherocytosis, autohemolysis test. Second test for the acquired hemolytic anemia. For the immune hemolytic anemia, we have to go for the Combs test. And for the paroxysmal nocturnal hemoglobinuria, we have to go for the sucrose hemolysis test, Hem's acidified serum lysis test, and flow cytometric analysis. So this is all about the hemolytic anemia. Now we will see the various picture we can see in the peripheral smear. First is anisocytosis, means different sizes of the RBC is called anisocytosis. In the smear we can see the few small RBC, few large RBC. Now poikilocytosis is called different shapes of the RBC. You can see a helmet cell, fragmented cell. Now next is a target cell. We can see the RBC having a target lesion seen in the liver disease, thalassemia, HBT disease and the post-splenectomy. Next is a teardrop cell seen in the myelofibrosis, infiltration of the bone marrow, tumors of the bone marrow and thalassemia. Spherocytosis are the smaller RBC without central pillar seen in the hereditary spherocytosis. Elliptocytosis is seen in the hereditary elliptocytosis. Stomatocytes having a slit-like central pillar seen in the liver disease, acute alcoholism, H. stomatocytosis and malignancy. Echinocytes, evenly distributed spicules more than 10. It's also called a Burr cell seen in the uremia, peptic ulcer, gastric carcinoma and PKD. Acanthocytes, 5 to 8 spikes of the varying length and irregular interval called spur cell occur in the autoimmune hemolytic anemia. Cystocytes, fragmented cell, helmet cell or triangle shaped cell seen in the microangiopathic hemolytic anemia, cruciatic valves, uremia and the malignant hypertension. Howell-Jolly body is seen in the absence of the splenic function. It is a nuclear chromatin in a RBC. You can see a single dot like. Now next topic is the reticulocyte count. These are the young premature non-nucleated red cell and contains a reticular material that stains grey-blue. Reticulum is present in the newly released red blood cells from 1 to 2 days before the cell reaches the full mature stage. The RBC have a 6 stages of the development. First is a pronormoblast, second basophilic normoblast, then prochromatophilic normoblast, orthochromatophic normoblast, reticulocyte and mature red cell. Up to orthochromatic normoblast seen in the bone marrow. Reticulocyte is seen 2 to 3 days in the bone marrow and 1 day in the peripheral blood, and mature red cells are present in the peripheral blood only. Now stain for the reticulocyte is visualized by the supravital stain such as a new methylene blue, brilliant crescent blue, pure azure blue that precipitate the RNA and organelles forming a filamentous network of the reticulum. On a right stain, the reticulocyte appear as a polychromatophilic or as a macrocytic blue-red cell. Normal range is a 0.5 to 1.5 per 100 red blood cell or 0.5 to 1.5%. In the newborn, it is a slightly higher 2.5 to 6%. These are all the reticulocyte. The reticulocyte count increased is called reticulocytosis. Is called when the reticulocyte index more than 3% and reticulocyte count more than 1.5%. Seen in the acute blood loss, hemorrhage, post-splenectomy, acute hemolytic anemia, hemoglobinopathies like sickle cell thalassemia, post-anemia treatment like a folate supplement, iron supplement, B12 supplement. In all this condition, bone marrow is hyperactive, so it is producing more red blood cell, and the red blood cell these are coming in the circulation, so there is a increased reticulocyte count. Now reticulocytopenia is called when the index is less than 1 and count is less than 0.5. Seen in the aplastic anemia, bone marrow infiltration, bone marrow supplement failure like a sepsis, chemotherapy, radiotherapy. Disorder, RBC maturation like a IDA, B12, folate deficiency, cytoplastic anemia, anemia of the chronic disease, hypothyroidism, blood transfusion and liver disease. In this, the bone marrow is not forming the RBC, so the count is decreased. Now, sickle cell. Sickle cell anemia is an inherited disorder that leads to the production of an abnormal hemoglobin variant like a hemoglobin S. Hemoglobin S production arises from an altered S gene in which the glutamic acid is replaced by the valine at the 6th position of the beta chain. For the sickle cell, there are various tests available. First is a slide test. for which the principle is when the red cell containing the hemoglobin S are deprived of the oxygen, they become sickle shape. A reducing agent that is used to remove the oxygen from the red cell is a 2% sodium metabisulfate procedure, in which the drop of the blood is mixed with the 2% metabisulfate on the slide. The cover slip is placed on the mixer and sealed with the petroleum jelly, paraffin wax. The preparation is examined under the microscope after the 30 minutes. If the red cell are become sickled, test is positive. If the red cell remain round, the test is negative. Second is a solubility test for the hemoglobin S. Principle is the anticoagulated blood is added to the reagent solution consisting of phosphate buffer, saponin, sodium dithionine. The RBC are hemolyzed and the HbS, if present, is reduced by the dithionine and the solution appears turbid. The presence of the hemoglobin S is indicated by the turbid solution. The hemoglobin like HbA, HbF, HbC, HbD, HbG under this same condition result in a clear non-turbid solution. You can see in the figure, first is a negative test. In this we can see the clear line through the test tube, and second is a positive test. The solution became turbid and we cannot see the line behind the test tube. Now second is a HPLC. What is the chromatography? It is a technique for separating the mixture into their components in order to analyze, identify, purify or quantify the mixture or the component based on the different affinity to the either the mobile or the stationary phase. The various constituents of the mixture travel at a different speed and causing them to separate. In this we can see in the figure, first there is a mixture is present and we are separating it by the HPLC, and substance are separated and we do analysis, identify, purify and quantify this substance. So we are having the HPLC machine. You all have seen in your orientation at the sickle cell laboratory. We are having the HPLC machine. So HPLC machine have a various part. First, having a control and data processing. Second is a pump, auto sampler, HPLC column, fraction collector and the waste. After the sample is placed in the machine, we will auto analyze the sample. Various signals are detected by the fraction collector and detector, and these signals are sent to the control data and processing unit. From that we can collect our report. In the HPLC, the various we are doing mainly for the hemoglobin separation. So we are having a various different type of the hemoglobin present in the normal adult as well as in the patient having any hemoglobinopathies. So different hemoglobin have a different time at which they are separated. So it called retention time. So here is the retention time of the different hemoglobin. First, hemoglobin F1 is separated at the 1.12 minute. Hemoglobin P2 at the 1.32 minutes. P3 at the 1.69 minutes. HbA at the 2.51 minute. HbA2 at the 3.6 minute. D window at the 4.12 minute. S window at the 4.46 minute. Unknown window at the 4.79 minute. And HbA coelute with a HbA2. So the graph is plotted according to the retention time and concentration, and we have to interpret the graph. This is the normal chromatograph. In first spike is of P2, which is a 5.4%. Second peak is a P3, which is a 3.5%. And third, the larger peak of is a A0, which is a 88%. And last peak is of A2, which is a 2.9%. So this is the normal chromatograph seen in the normal individual. Second is a beta thalassemia major. We can see the F hemoglobin concentration is increased 91.3%. A2 is reduced 4.4% and A2 is a 4%. This is the case of the beta thalassemia major. Now next is a sickle cell homozygous, in which the hemoglobin S is a more than 50%. Hemoglobin, we can see in the graph, is hemoglobin F is 18%, A0 is a 1.8%, A2 is 2.8%, and S window is 77.1%. So from the HPLC we can detect the hemoglobin S disorder, hemoglobin thalassemia disorder, hemoglobin D Punjab disorder, hemoglobin E disorder. Now last topic is the automated hematology analyzer. Automation is a process of the replacement of the task performed by the human by the computerized method. It works on the different principle, which includes electric impedance, light scatter, fluorescent, light absorbent, electric conductivity. Automated analyzer are of two types. First is a semi-automated and second is a fully automated. Semi-automated, some step like a dilution of the blood sample are performed by the technological staff, and it can measure only few parameters, while the fully automated machines require only anticoagulated blood sample and measures the multiple parameters. What are the advantages of the automated hematology analyzer? First, a speed with efficient handling of the larger number of the sample. Second, accuracy and the precision of the quantitative blood test. Ability to perform a multiple test on a single platform. A significant reduction in the labor requirement. Invaluable for accurate determination of the red cell indices. Disadvantage of the automated hematology analyzer are flags. Flagging of the laboratory test results demand labor, intensive manual examination of the blood smear is needed. Comments on the red cell morphology cannot be generated. The abnormal RBCs cannot be recognized. Enormously increase or decrease in the result due to the interfering factor. The expensive with a high running cost. These automated hematology analyzer are of various type according to the parameter measured. So according to the WBC parameter, it is a 3-part, 5-part and 7-part. So first in the 3-part, the WBC parameter measured are lymphocyte, monocyte and granulocyte. Granulocyte includes a neutrophil, eosinophils and all other granulocytic cell are included in the granulocyte. Then monocyte are counted as different and the lymphocyte is counted as different. In the 3-part, beside WBC, all the RBC parameter, platelet parameter are measured. Next is a 5-part. In the 5-part differential, the WBCs are counted as a lymphocytes, monocyte, neutrophil, eosinophils and basophils. And plus various RBC parameter are also added like a reticulocyte count and various parameter for the reticulocyte count. It can be also measured in the 5-part, and different platelet parameters are also measured in the 5-part. So total around 45 parameters can be measured in the 5-part. This is the 5-part hematology analyzer we are having at our lab, New Civil Hospital, Surat. This is the 7-part hematology analyzer located at the New COVID Hospital. In the 7-part, total 5-part WBC parameter that we have shown, the lymphocyte, monocyte, eosinophil and neutrophil, plus various immature cell, blast cell, this atypical cells, this also measured, and different RBC parameter, platelet parameter, reticulocyte count. Total around 72 parameters can be measured in the 7-part. These are the various part present in the machine, like a rack loader in which we load the sample. Then the reagent